Welcome back to Healthcare Systems. Part 3 will focus on healthcare systems around the world. So, as already noted when I discussed theories of distributive justice, different countries take various approaches to how they fund and deliver healthcare to their population. One way to think about how Canada is doing is to compare Canada based on data collected by the Organization for Economic Cooperation and Development, OECD, to what are called peer countries. You have seen some examples of these peer countries in the Martin and colleagues article, for example, the UK, France, Germany, Australia, and the US. The OECD helps governments around the world and promotes policies that will improve the economic and social well-being of people globally. Canada, unfortunately, does not do as well as you might have thought when compared to other countries, especially when the idea of health includes socioeconomic determinants of health. Health, as you know, is not simply the absence of disease, and the Canadian approach to population health has been long recognized that health is a capacity or a resource. Health is not a state of being. Rather, health is more about having the ability to pursue your goals, acquire skills and education, and grow. This broader understanding of health therefore recognizes the range of social, economic, and physical environmental factors that contribute to health. But Canada is rife with social inequities that contribute to us doing poorly compared to 15 other peer countries. For example, with regard to poverty, as of 2017, Canada scored a C grade and ranked 13 out of 16 peer countries. These were Australia had a C, Japan a D, the US a D, and they are lower than Canada. Denmark was number 1, then Finland, France, Norway, Netherlands, Ireland, Sweden, Germany, Australia, Switzerland, and Belgium. Canada has the second highest rate of child poverty amongst OECD peer countries, ahead of the US, with the rate hovering between 14 and 17% in recent years, and it is at the higher end for Ontario. The most recently reported results from Statistics Canada from the 2016 census show that nearly 1.2 million children across Canada live in poverty, approximately 17% in 2015. So more than 1 in 7 Canadian children live in poverty. The population of older adults continues to increase in Canada. People are living longer, but not necessarily in good health or with adequate income. People are living longer, though Canada ranks in 5th place compared with peer countries, such as Netherlands is the best, Australia is the worst, poverty among older people is about 12.5% nationally and seems to be rising. If you only were to examine the numbers who live alone, then the percent increases drastically, with 15% of women and over 11% of men who live alone live in poverty. Many older adults need to work to survive. They may face economic hardship and have limited resources to meet their growing health needs. Countries spend a lot on health. However, they do not always spend their money as well as they could. The OECD reported in 2019 that spending on health was approximately US dollars 4,000 per person, on average across OECD countries. The US spent more than all other countries by a considerable margin, at greater than US $10,000 per resident. Many high-income OECD countries, though, such as Germany, France, and Japan, spend 50% or less than the US. The UK and Italy are around the OECD average. Lowest per capita spenders are Mexico and Turkey, with health expenditure at around a quarter of the OECD average. China spends about 20% of the OECD per capita spending level, whereas both India and Indonesia spend less than 10%. Canada was expected to spend approximately $7,068 per person, so approximately US about $5,200 per year, which is higher than the OECD average, and yet we still don't have the best outcomes on some measures compared to peer countries. Health expenditures have been outpacing economic growth in all OECD countries, and it is estimated that health spending will reach 10.2% of the GDP by 2030 across OECD countries, up from 8.8% in 2018. In Canada, total health expenditure in 2019 was expected to be 11.6% of our GDP, and that was before the pandemic. This increase in costs raises sustainability concerns, not only in Canada, but also in other countries, particularly as most countries draw funding largely from public sources. So reforms are needed to improve economic efficiency. Also, the aging population is contributing to increasing demand for health services, particularly for long-term care, and by 2050, the percentage of the population aged greater than 80 is expected to more than double. There's a positive association between health spending per capita and life expectancy. Amongst the 36 OECD countries, 17, including Canada, spend more and have higher life expectancy than the OECD average, and 10 countries spend less and have lower life expectancy than the OECD average. But in 8 countries, Italy, Korea, Portugal, Spain, Slovenia, Greece, Israel, and New Zealand, they spend less than average but have higher life expectancy overall. The US is the only country that has lower life expectancy than the OECD average despite much higher spending than the average. Population coverage for a core set of health services. So most OECD countries have achieved universal or near universal coverage for a core set of health services that usually include consultation with doctors, tests and examinations, and hospital care. Financing is usually through national health systems or social health insurance, though a few countries, Netherlands and Switzerland, use compulsory private health insurance that is supported by public subsidies and laws, re the scope and depth of coverage. In 7 OECD countries, however, population coverage is below 95%. In Mexico, the US, and Poland have the lowest population percentage of coverage, despite the 2014 Affordable Care Act. And the US government are currently trying to get rid of this act, even during a pandemic with all the illness and unemployment. Voluntary private insurance is also available in some OECD countries, including Canada. Such insurance can, for one, cover any cost sharing left after basic coverage, so that's complementary insurance. 2, add further services, so supplementary insurance, or 3, provide faster access or larger choice of providers, which is duplicate insurance. 8 OECD countries have additional private insurance coverage for over half of the population, and in France, 90% of the population have complementary insurance to cover cost sharing in the social security system. Complementary insurance is also widely used in countries such as Belgium, Slovenia, and Korea. Israel and the Netherlands have the largest supplemental market, over 80% of the population. So private insurance pays for dental care, physiotherapy, certain prescription drugs, and other services not publicly reimbursed, which is similar to Canada. Duplicate private health insurance provides faster private sector access to medical services where there are waiting times in public systems. Largest percentage are in Ireland and Australia. In the United States, 8% of the population has complementary private health insurance, which is in addition to the 55% of the population with primary private health insurance. So, there are variations by countries in the ways in which health services are funded and delivered to our country's population. But spending a lot on healthcare does not necessarily equate to the best outcomes. Canadians can learn from some other countries as we struggle to consider how best to fund our system that is not as efficient or as comprehensive as it could be. So stay tuned for our Zoom meeting, which will be September the 22nd from 3 to 4 p.m. And we will discuss some of these concepts in a little bit more detail. See you then.